that hasn't been identified. And you can see here that one of three things happen when there's pelvic floor contraction during voiding. Either the detrusor continues and you empty the bladder, or the detrusor is dampened a little bit, or it stops contracting and you have to strain to empty the bladder. It's a very serious condition, and 20 years ago in Australia, I don't think we looked for it at all. And what we're then running the risk of is that there are children having high pressure systems, and their response to that is that the muscles inside the bladder, the detrusor, contract a lot. And remember, I told you if you look in cystoscopy, you see this mesh network like chicken wire, but really thick. That gets thicker and thicker. That's called being trabeculated. You do get the pressure being pushed up through the ureteric orifices and up to the upper tract. You run the risk, therefore, of renal damage. Bladder doesn't empty properly. You set it, therefore, up to have infections. It may then be that the detrusor decompensates, so it becomes less able to contract, hypercontractile, very serious in the end. So somewhere along this continuum, you're going to see somebody with voiding dysfunction. Now, just the one thing I want to point out to you here is dermatitis. I don't know about you, but I'm not an expert in skin conditions. But I will feel very, very silly if I find out that what I've been treating as a voiding disorder problem is really just that the urine stings when it passes the skin. And you need to find somebody in your team who can upskill you in dermatitis of the vulva and that region, so that you recognize it when you see it and you recognize the symptoms. Now, when issues of the bladder coexist with issues of the bowel, we have to pay attention. We now call this bladder bowel dysfunction. We used to call it elimination syndrome. It's a long recognized coexistence, but as a condition, we're still evolving our understanding of it. I'm more interested if they're both emptying disorders. If there's a voiding dysfunction that goes with an emptying dysfunction of the bowel, I'm very interested, because I think that there's the commonality of increasing the outlet resistance, and maybe we can do something about that. But this bladder bowel dysfunction is any bladder problem, filling or emptying, and any bowel problem, transit or retention or emptying. And we are now documenting this far more. They are associated, but the jury is out on exactly how. But we know, we've just had a paper published that showed, it's a very unusual study, but it showed that when we have bladder bowel dysfunction and you just treat the bowel, then in a significant proportion of cases, the bladder symptoms will change and improve. They won't go away, but it's a very good treatment cascade to treat the bowel first. And then you see what is the residual bladder problem and you manage that. Now, what would be the signs of this? Well, there might be incontinence from both systems. You're going to hear about the bowel, but if you have fecal incontinence, you will have to suspect that what is coming out and leaking is coming around something else that's still inside, some stool. You'll find that probably the bowel training wasn't completed properly, so that the child didn't develop a good sensation of full rectum and didn't know how to prepare to let the pelvic floor relax, so that you can get funneling of the bottom of the rectum and the anal canal, and didn't know actually how to assist the stool to come out. You find that the stool quality is poor, because if you don't have a nice heavy, firm stool, you don't get as much sensation on the mechanoreceptors inside the rectum. And you'll find that the voiding is irregular, and often there's a post-void residual. Let's just say that if you're looking at symptoms of the lower urinary tract, they probably don't just occur in isolation, one symptom. They form patterns. As you could see on those urodynamic traces, there are patterns, aren't there, between where the pressures are generated in the filling and the emptying. I'd like to tell you that it's morning tea time, but it's not. Can I ask you if that made sense, if you understand that? It's quite overwhelming and it does take a long time to put the process together, but please come and talk to me if something just didn't make sense to you. Do you have a moment for questions? You can ask now, actually, if there's something you'd like clarified. Yes? Okay. We're not sure that the continuum is an entity. I think it probably is, but basically if you've gone from a high pressure system and then you evolve into a hypocontractile detruser, so you have a lot of urine in there, you can't get it out, you can't empty it. Sometimes there needs to be a surgical intervention to help the bladder to empty, to stop it being over-distended. Of course, you would also start with some catheterization long before it got to that phase. No, the surgery being catheterizable stoma or something like that. I'm just scaring you, really. I'm just saying there are consequences if we miss some of these important signs. Okay, so you can talk to me later. Thank you very much.
Thank you very much for that, Wendy. Very interesting talk, and it's a good foundation for the rest of the day. And Wendy actually touched on a few things that our next presenter will go into in a bit more detail.